Hi, welcome to the slideshow on radiobiology of radiotherapy and radiosurgery. The objectives are to describe different types of radiation and their biologic and physical properties, to understand how radiation damages cells, understand radiation sensitivity in different phases of the cell cycle, and understand the capabilities of modern radiation techniques. Two commonly used instruments for delivery of radiation therapy include the linear accelerator and gamma knife units. A linear accelerator, or LINAC, is shown on the left-hand panel. The LINAC is the workhorse of radiotherapy. It is capable of performing both conventional radiation and LINAC-based radiosurgery. Linear accelerators can use X-rays and electrons to treat, depending on the treatment target. X-rays are much higher energy than the X-rays used in diagnostic X-rays. The patient lies on the radiation table, which is denoted by the long arrow, and the table can move in multiple directions, with some tables having up to 6 degrees of freedom. The gantry can also rotate 360 degrees around the table, and the collimator can rotate 360 degrees as well. Within the machine head is a multi-leaf collimator that can be used to shape the radiation field and modulate the intensity of radiation for IMRT treatments. CyberKnife radiosurgery is a specific type of radiosurgery in which a small linear accelerator is mounted onto a robotic arm. On the right-hand panel is a gamma knife radiosurgery icon unit. Gamma knife radiosurgery uses up to 192 cobalt-60 sources. Beams converge onto a point in the brain to deliver a shot of radiation. Multiple shots are used to cover a target volume and allow sub-millimeter accuracy. The radiation dose outside of the target is minimal. There are both frame and mask-based systems. A mask facilitates treatments with multiple sessions and are useful for treatment of large targets and multiple brain metastases. Image guidance is provided with cone beam CT, and a camera is used to detect movement of the patient during these mask-based treatments. So how do you choose the type of radiation you want to use, and how do you choose the appropriate energy? Here are depth dose curves of photons, electrons, and protons. X-rays and gamma rays, shown in red, have no mass. They require dose buildup at the entrance when they reach tissue. They deposit maximum energy at a certain depth. The higher the energy, the greater the depth of maximum energy deposition, or Dmax. So for treatments of targets such as brain tumors that are not too deep, lower energy photons such as 3 to 6 megavolt photons can be used. For deep targets such as abdominal tumors, higher energy photons, for example 10 to 18 megavolt photons, may be used. These higher energy photons have skin-sparing properties due to low energy deposition superficially. Even with brain radiation, you can see changes in superficial tissues, for example, skin erythema or tanning, and hair loss due to low doses of radiation at the entrance and exit points. Electrons and protons are particles and have a mass. Electrons have greater dose deposition superficially than photons and are useful for treating skin lesions. Protons have much greater mass than electrons, about 1,000 times greater. Therapeutic protons have energies of 200 to 215 MeV and are generated by cyclotrons. Protons deposit energy in a narrow depth dose, seen as a sharp peak on the depth dose curve. This is known as a Bragg peak. Minimal energy is deposited beyond this depth. Radiation oncologists can design radiation plans such that the Bragg peak is centered on the target volume. thereby minimizing exit doses outside of the tumor. Proton therapy is particularly useful for treatment of pediatric cancers and spinal tumors, and may also reduce long-term toxicity in adult patients receiving partial brain irradiation. Dose distributions of photon and proton plans from patients with medulloblastoma receiving craniospinal irradiation are shown. Here you can see sagittal images of their radiation plans. Isodose lines are seen, and these isodose lines are similar to topographic maps. Isodose lines show areas or volumes receiving at least that particular dose. In red is the 50 gray isodose line, in blue is the 36 gray, and orange is the 26 gray isodose line. The photon plan is shown on the left, and proton plan on the right. In the photon plan, the low-dose orange 20 gray irradiation volume extends to the patient's anterior. The finger-like region where the blue 36 gray isodose line extends to the patient's lower anterior abdomen is due to exit doses from the two adjacent spine fields used in this plan. Hot spots shown in red are seen in the lower cervical, upper thoracic back, and lower lumbar, upper sacral areas. On the right is the proton plan. The low-dose 20 gray isodose line does not extend into the patient's abdomen. The high-dose 50 gray hotspot regions in the photon plan are avoided in the proton plan. The reduction in exit dose can reduce acute and long-term side effects of radiation. The decrease in radiation to vertebral bodies, heart, bowel, reduces the risk of short stature, bone marrow suppression, cardiac abnormalities, and acute side effects of nausea, vomiting, and diarrhea that can be associated with craniospinal irradiation. With proton therapy, there is a reduction as well in radiation-induced cancers due to reduction of the exit dose. Proton therapy is particularly useful in children. It may also be considered in adult patients that are expected to have long-term survival, for example, patients with low-grade gliomas or meningiomas receiving partial brain irradiation, and studies have shown a reduction in neurocognitive and neuroendocrine deficits in patients receiving proton therapy. Linear energy transfer, or LET, is the average energy deposited per unit length of track. It describes the pattern of energy deposition within a photon or particle track. Radiation therapy is generally considered low LET radiation. As seen in this figure, X-rays and cobalt-60 gamma rays exhibit relatively sparse energy deposition within their tracks. Some types of radiation, for example, neutron or carbon-13 ion radiation, are considered high LET radiation. High LET radiation is densely ionizing and deposits significantly more energy within its track. A term related to LET is relative biologic effectiveness, or RBE. RBE is used to describe the biological effectiveness of radiation of different qualities. RBE is the ratio of the dose used to reach a biologic endpoint using 250 kVp X-rays compared to the dose using radiation of a different LET. Higher LET radiation generally has a greater RBE than lower LET radiation. Protons have an empirical RBE of 1.1 in the Bragg peak region, which is only slightly higher than that of photons or X-rays. In contrast, carbon ion therapy has a higher RBE of about 1.3 to 5. Therefore, for the same dose delivered with X-rays, carbon ion therapy has a greater biologic effect. When X-rays or particles traverse tissue, they deposit energy in their tracks. This energy causes ionization of molecules. These ionizations produce free radicals that cause damage to molecules, including water, lipids, proteins, and importantly, DNA. The ejected orbital electrons themselves can create additional ionization events. These ionizations can then create additional free radicals and secondary electron ejection. This cascade of events continues until the energy of photons or electrons is too low to cause any more ionization. Ionization occurs randomly. Since water is most prevalent in cells, it is more frequently ionized and produces free radicals. These free radicals cause DNA damage. Radiation, which is primarily low LET radiation, occurs mostly via indirect action. That is, radiation causes ionization of a water molecule or other intermediary to form hydroxyl radicals, which then go on to cause DNA damage. Direct action occurs when DNA itself is damaged. With low LET radiation, 2/3 of DNA damage occurs through indirect action and 1/3 occurs through direct action. Ionizing radiation causes damage to cells. The most important is DNA damage. Cells sense DNA damage and make a decision to live and repair the DNA or die. If too much DNA damage occurs and cannot be repaired, cells will be programmed to die. If damaged cells do not die and DNA damage remains unrepaired, then the cells may undergo permanent growth arrest. Alternatively, cells may exhibit genomic instability that contributes to malignant transformation. Different types of DNA damage can occur. These include single-strand breaks and double-strand breaks, mutations, chromosome breaks that can result in loss of part of the chromosome or the whole chromosome. Chromosome breaks can also lead to translocations. These changes can cause cell death or in some cases facilitate malignant transformation or resistance to therapy. The therapeutic ratio is based on radiation effects in normal tissues and cancer cells. An optimal therapeutic ratio exhibits widely separated normal tissue complication curve, shown in blue, and tumor control curve, shown in red. A suboptimal therapeutic ratio exhibits closely spaced curves. Unfortunately, the therapeutic window for tumor cells often overlaps with the normal tissue complication curve. The therapeutic ratio may be improved by the use of radioprotectors that shift the normal tissue complication curve to the right, or radiosensitizers that shift the tumor control curve to the left. Classical radiation biology is largely descriptive of responses of cells and tissue to radiation. Clonogenic survival is the functional readout. It describes the survival of clonogens, or cells that have replicative potential after radiation exposure. On the left is the target theory. It says that the same proportion of cells is killed with each increment of radiation. This is reflected in the survival curve showing a straight line after the initial curve. On the right is the linear quadratic curve. The linear quadratic curve was developed to better describe experimental data of cell survival. Cell death can occur with one-hit and two-hit mechanisms. These are graphed as the linear term and quadratic term, respectively. Many tumor cells demonstrate a linear quadratic cell survival curve with a linear term, alpha D, and quadratic term, beta D squared. This linear quadratic model is frequently used in clinical practice and facilitates calculation of biologically equivalent doses of radiation. These equations are used when comparing different radiation fractionation schemes. Fractionating radiation can improve tumor response while sparing normal tissues. Fractionating radiation reproduces the early shoulder portion of the cell survival curve. This differs between normal tissues and tumors, thereby creating a larger therapeutic ratio with fractionation. Conventional fractionation refers to daily radiation fraction sizes of 1.8 to 2 gray. The typical dose ranges from 50 to 70 gray, depending on the tumor type being treated and the intent of treatment. Alternative fractionations include hypofractionation schemes, commonly used for whole brain radiation, for example, 3 gray per fraction for 10 fractions, for a total dose of 30 gray. The concept of radiation fractionation is supported by the 5 R's of radiation biology. These are repair, redistribution, reoxygenation, repopulation, and radiosensitivity. Ionizing radiation causes damage to many molecules, most importantly, DNA. The first R is repair, specifically DNA damage repair. The most lethal type of DNA damage is the double-strand break, but other types of DNA damage may occur as well. For example, single-strand DNA breaks, mismatches, and crosslinks. DNA damage is sensed by the cell and initiates the DNA damage response. The specific pathway that is initiated depends on the type of DNA damage detected and the cell cycle phase. When DNA damage is detected, cells can arrest to permit repair of DNA damage before proceeding through the cell cycle. Checkpoints occur within each phase of the cell cycle to maintain the integrity of DNA. Since double-strand break repair is the most important in radiation therapy, we will briefly touch upon 2 types of double-strand break repair. These are non-homologous end joining and homologous recombination. Non-homologous end joining is error-prone and occurs predominantly in G1 phase. Homologous recombination is more faithful. It requires a sister chromatid to serve as a template for repair, so it primarily occurs in late S phase. Ionizing radiation causes damage to many molecules, most importantly, DNA. The first R is repair, specifically DNA damage repair. The most lethal type of DNA damage is the double-strand break, but other types of DNA damage may occur as well. For example, single-strand DNA breaks, mismatches, and crosslinks. DNA damage is sensed and initiates the DNA damage response. The specific pathway that is initiated depends on the type of DNA damage detected and the cell cycle phase. When DNA damage is detected, cells arrest to permit repair of DNA damage before proceeding through the cell cycle. Checkpoints occur within each phase of the cell cycle to maintain the integrity of DNA. Since double-strand break repair is the most important in radiation therapy, we will briefly touch upon 2 types of double-strand break repair. These are non-homologous end joining and homologous recombination. Non-homologous end joining is error-prone and occurs throughout the cell cycle. Homologous recombination is more faithful. It requires a sister chromatid to serve as a template for repair, and so it occurs in late S phase. Gross chromosome changes can be seen after ionizing radiation. On the left, you can see breaks in 2 different chromosomes colored blue and yellow. These breaks may result in balanced translocations. These rearrangements may result in chromosome fusions with 1, 2, or no centromeres. On the right are 2 breaks in 1 chromosome, which can lead to chromosome rearrangements, DNA rings, or loss of DNA fragments. Acentric chromosomes may be lost in subsequent rounds of replication. The next R is redistribution. This refers to redistribution of cells in different phases of the cell cycle. The cell cycle includes interphase, G1, S, and G2 phases, and the mitotic or M phase. Cells are most sensitive to radiation in the G2M phases and least sensitive in late S phase. In S phase, double-strand breaks can be repaired by both non-homologous end joining and homologous recombination. In G2M phases, cells primarily repair double-strand breaks by non-homologous end joining. Radiation can redistribute the proportion of cells in a particular phase of cell cycle. Fractionated radiation can improve the radiosensitivity of the tumor. Cells that are in the more sensitive phases of the cell cycle are killed. Cells that are in the most radioresistant phases of the cell cycle may continue to progress through the cell cycle. At the time of the next fractionation of radiation delivery, those cells may be in a more sensitive phase of the cell cycle. Over the course of radiation, say 5 to 6 weeks of radiation, most of the cells should have redistributed to a more sensitive phase of the cell cycle for at least some fractions of radiation. Radiation can also cause cell cycle arrest. Cells that have repaired DNA may be synchronized in a more radiosensitive phase of the cell cycle when the next fraction of radiation is delivered. Reoxygenation is the third R. Therapeutic radiation is dependent on oxygen. In fact, oxygen is the most important radiosensitizer. Oxygen participates in the generation of free radicals that cause DNA damage. The dose needed to kill cells is about 3 times greater under hypoxic conditions than normoxic conditions. Hypoxia in tumors such as glioblastoma contributes to radiation resistance. Fractionating radiation can improve cell killing by facilitating reoxygenation. As shown in the figure, a tumor mass contains normoxic and hypoxic regions. With a dose of radiation, the normoxic cells are killed, leaving behind the hypoxic tumor cells. As the tumor mass shrinks due to cell killing, cells that were in previously hypoxic areas may now be normoxic. With the next fraction of radiation, these normoxic cells are killed, leaving behind a smaller fraction of hypoxic cells, and these cells may now become normoxic. So with each fraction of radiation, the tumor mass decreases and the proportion of hypoxic cells also decreases. The fourth R is repopulation. Cells that survive radiation can divide and repopulate the tumor. Cancer cells can undergo accelerated repopulation due to shorter doubling times. In some cancers, such as head and neck cancers, longer overall treatment time results in poor outcome. For this reason, prolonged treatment breaks are discouraged. A higher dose of total radiation is needed to kill off the repopulated tumor cells. For this reason, it is better to delay the start of radiation than to have a treatment break during radiation. The fifth R is radiosensitivity. Different cells have inherent differences in their radiosensitivity. Many factors contribute to the radiosensitivity of cells. For example, some cells may repair DNA damage more efficiently than others and may have higher thresholds for apoptosis or other forms of cell death. Cancer stem cells, for example, are highly radioresistant. Other cells, for example normal stem cells and bone marrow cells, are very radiosensitive. This is important because cells that have DNA damage are eliminated so that mutated or damaged DNA is not transmitted to daughter cells. Some tumors are more sensitive to radiation than others. Radiosensitive tumors include small cell cancers and lymphoma. Other cancers, such as melanoma, sarcoma, and renal cell cancers, are relatively radioresistant. Different radiation planning strategies can be used to develop the optimal plan that treats the tumor while minimizing the amount of normal tissue irradiated. In general, multiple radiation beams are used to achieve a conformal dose distribution. Like spokes on a bicycle wheel, radiation beams converge to form a high-dose radiation volume within the target volume. Dose conformality is achieved at the expense of a spread of lower radiation doses to a larger volume of tissue. Common radiation techniques include 3D conformal irradiation, IMRT, and volumetric modulated arc therapy, or VMAT, a form of IMRT. Stereotactic radiosurgery and fractionated stereotactic radiosurgery, also known as fractionated stereotactic radiotherapy, are highly conformal radiation techniques. Image guidance is frequently used with all of these techniques, and the inclusion of image guidance is termed image-guided radiotherapy. IMRT is intensity modulated radiation therapy. IMRT is an advanced radiation planning technique that can use hundreds to thousands of beamlets to deliver highly conformal radiation. Here is an example of the dose distribution from an IMRT plan for a patient with glioblastoma. The 51 gray and 60 gray planning target volumes are shaded in blue and red, respectively. The brainstem is shaded in green and optic chiasm is shaded in yellow. Isodose lines are indicated as follows. 63 gray line is in yellow, 60 gray line in turquoise, 51 gray line in green, and 20 gray in orange. Note that the 60 gray isodose line conforms to the 60 gray planning target volume and excludes the brainstem and optic chiasm. The 51 gray isodose line conforms to the 51 gray planning target volume, which encompasses the brainstem and chiasm. This lower dose is within radiation tolerance of the brainstem and chiasm. In IMRT plans, the low dose volume of irradiation, the orange 20 gray line, includes the majority of the brain. Different radiation planning strategies can be used to develop the optimal plan that treats the tumor while minimizing the amount of normal tissue irradiated. In general, multiple radiation beams are used to achieve a conformal dose distribution. Like spokes on a bicycle wheel, radiation beams converge to form a high-dose radiation volume within the target volume. Dose conformality is achieved at the expense of a spread of lower radiation doses to a larger volume of tissue. Common radiation techniques include 3D conformal radiation, intensity modulated radiation therapy, or IMRT, and volumetric modulated arc therapy, or VMAT, a form of IMRT. Stereotactic radiosurgery and fractionated stereotactic radiosurgery, also known as fractionated stereotactic radiotherapy, are highly conformal types of radiation. Image guidance is frequently used with all of these techniques, and the inclusion of image guidance is termed image-guided radiotherapy. IMRT is an advanced planning technique that can use hundreds to thousands of beamlets to deliver highly conformal radiation. Here is an example of the dose distribution from an IMRT plan for a patient with glioblastoma. The 51 gray and 60 gray planning target volumes are shaded in blue and red, respectively. Brainstem is shaded in green and optic chiasm is shaded in yellow. Isodose lines, including the 63 gray line, is shown in yellow, 60 gray line in turquoise, 51 gray in green, and 20 gray in orange. Note that the 60 gray isodose line conforms to the 60 gray planning target volume and excludes the brainstem and optic chiasm. The 51 gray isodose line conforms to the 51 gray planning target volume, which encompasses the brainstem and chiasm. This lower dose is within tolerance of the brainstem and chiasm. In IMRT plans, the volume of low-dose irradiation, shown by the orange 20 gray line, includes the majority of the brain. Stereotactic radiosurgery can treat smaller tumor volumes with high conformality and steep dose falloff. Gamma knife radiosurgery plan for a patient with a pituitary macroadenoma invading the cavernous sinus is shown. Here you can see the coronal, axial, and sagittal sections of a patient plan showing a steep dose falloff. The yellow 15 gray isodose line encompasses the tumor volume shown in dark blue. The green 8 gray isodose line is also shown and excludes the optic chiasm shown in light blue. Here are a few take-home points. Radiation can be delivered by X-rays, gamma rays, and particles. Radiation causes cell death by damaging cells, in particular by causing DNA double-strand breaks. Cells in different phases of the cell cycle can exhibit different radiosensitivities. Cells in the G2M phase of the cell cycle are more sensitive than cells in the S phase. Modern radiation is highly conformal and can be performed with image guidance to ensure accurate targeting.